Good morning everyone, I'm O.Javed. I'm a registrar working at Cheltenham and Gloucester, and I'll be presenting our team's study on revision ACL reconstructions with bone patellar tendon bone graft. ACL ruptures have an incidence of around 0.03%, rising to 3% in some studies of athletes, and the number of revision ACLs is going up. Common causes for failure of primary reconstruction include an incorrect tunnel position, further trauma, and failure of graft integration. Risk factors that increase the chance of a revision include a younger patient, small graft diameter, hamstring tendon used for the primary surgery, allograft, and suspensory fixation. Revision surgery tends to lead to worse functional outcomes and return to sports, emphasizing the need to get it right first time. Factors that can affect the planning of revision surgery include assessing the previous tunnel position and tunnel widening, bone loss, and which graft was used in the initial surgery, and the presence of any associated injury or infection. The goals of revision surgery are much the same as primary reconstruction, with the aim of improving stability to allow return to activities and prevention of further injuries and damage to the joint. So the aims and objectives of our study was to look at our results of a cohort of patients who underwent single or two-stage revision ACL reconstruction, assess their change in functional outcome scores before and after surgery, and assess the re-rupture rate in our cohort. We reviewed patients who had their revision surgery between January 2004 and 2017, and we excluded multi-ligament reconstructions, re-revisions, and revision for infection. We collected data on their demographics and information about their symptoms, and we recorded pre-op and post-op Lysholm and Tegner scores, as well as whether or not patients had returned to sports and at what level. Stats analysis was done using SPSS, using means and standard deviations for continuous variables, and paired t-test for functional score changes. A full history and examination was performed pre-op, and the original operation notes were reviewed. Blood tests were done and relevant imaging was requested. The tunnel position was classified, and if it was type 2, which meant malpositioned tunnels near the ideal revision surgery tunnel site, or if there was significant widening more than 14 mm, then the revision surgery was performed as a two-stage. Various surgical techniques were used during single-stage revision. In all cases of the revision surgery, bone patellar tendon bone was the graft of choice. In two-stage revisions, iliac crest bone graft was used in the first stage, anterolateral tenodesis was performed in certain patients who were hyperlax, and post-op, patients were allowed to fully weight bear as tolerated without a brace and had standard ACL rehab. We reviewed the outcome of 80 patients, with almost 3/4 of patients being male and an average age of around 30 years. Revision surgery took place an average around 4 years after primary reconstruction. 68 patients had a single stage and 12 had a two-stage, and additional procedures were performed in certain cases, as you can see. There was tunnel malposition in around 70% of cases of the primary reconstruction. Those who had a two-stage had a period of around 5 months between stages, and the overall average follow-up was almost 9 years post-op. 8 patients had grade 2 laxity on pivot shift test, but with activity modification they were happy to avoid further surgery. Patients had a significant improvement in their Lysholm score from an average of 52.4 to 85.1, and 66 patients had a Tegner activity score of 5 to 9. 2/3 of patients returned to sports, and there were no re-ruptures in our cohort. In conclusion, ACL revision surgery rates are increasing, and reported outcomes are not as good as primary reconstruction. It is important to reflect on why the primary reconstruction failed, and investigations such as weight-bearing X-rays, CT, and MRI should be considered. Tunnel malpositioning and widening may lead to a two-stage revision rather than a single stage, and our study has shown good functional outcomes with a 0% re-rupture rate with the use of bone patellar tendon bone graft and thorough pre-operative planning. Thank you.